Okay, so we're going to pick up where we left off on, so pemphigus vulgaris. This is a progressive, sorry, I'm moving this, a progressive severe disease affecting the skin and mucous membranes characterized by a bullae that ruptures and forms painful ulcers. So this sort of is similar in some ways to the pemphigoid from the first one that we covered at the beginning of the lecture. So oral manifestations, superficial ragged erosion and ulceration, haphazard distribution. So it's not like a nice little vesicle that pops. It kind of has more of a ragged outline. Most common area is the palate, labial mucosa, buccal mucosa, ventral surface of the tongue, and gingiva. For interventions, we want to consult with a physician for early diagnosis, monitor patients for long-term effects of treatment with corticosteroids and immunosuppressants. Pernicious anemia, this is a failure of the stomach to produce intrinsic factors and lack cobalamin or vitamin B12. So the oral manifestations of pernicious anemia: red, painful burning tongue with atrophy of the papilla and oral ulcerations. Patients might be using a topical pain control for the oral lesions and the sore tongue. Psoriasis, chronic inflammatory dermatosis characterized by well-demarcated pink to salmon-colored plaques covered by loosely adherent silver-white scales on the surface of the lesion. And approximately 15% of this is linked to arthritis or psoriatic arthritis. Oral manifestations are rare for psoriasis. Oral lesions appear as white or red plaques mixed with red and white lesions, pustules, vesicles, or ulcerations. Geographic tongue might occur in patients with psoriasis. We might consult with a dermatologist if we suspect there's an oral lesion, and topical pain control if there's a systematic lesion. Symptomatic, sorry, if I was like, that doesn't sound right, but if a lesion becomes symptomatic. And then rheumatoid arthritis, chronic inflammatory condition, principally attacking the joints and producing a suppurative or proliferative inflammatory synovitis characterized by pain, swelling, stiffness, and a loss of function. So it's inflammation in the synovial fluid. Synovitis is what it's, inflammatory synovitis, but it's inflammation in the synovial fluid. And oral manifestations for this would be TMJ involvement in about 75% of the cases, limited or difficult opening of the mouth, drug-induced gingival bleeding, drug-induced oral mucosal lesions. So innovations here is regular x-rays, regular panos to assess the mandibular condyle for wear and other TMJ issues. Patients might need to be on a softer diet, and that could be more cariogenic. So we have to be aware of that. And then moist, heat, or ice, depending on what the patient is in need of at that time. They might need an occlusal appliance. Their OHI might be limited ability due to their limited dexterity. Pre-medication could be indicated if they are have a significant immune suppression. Considerations, we got to think about their bleeding time, platelet function, and immunosuppressant. Those are medications they might all be on. Pain control, drug-induced oral lesions. Again, the shorter a morning appointment, difficulty getting in and out of the chair or sitting for a long time, and use supportive devices to maintain their comfort. So pillow behind the neck, behind maybe their low back or behind the knees, that sort of thing. Scleroderma is a chronic disease of the connective tissue secondary to vascular injury and progressive interstitial and perivascular fibrosis of the skin and multiple organs. It's like a stiffening and a shrinking sort of is what you see, better known as systemic sclerosis. So oral manifestations here can be pretty significant. Radiologically, we'd see widened periodontal ligament spaces, osseous destruction of the TMJ, mandibular angle, and coronoid process and condyle would all show signs of destruction on a radiograph. Jaw fractures late in the disease, microstomia, limited opening of the mouth, xerostomia, loss of attached gingival mucosa and generalized recession, firm hypomobile tongue. That's because of that stiffening of their connective tissue, difficulty with speech and swallowing. Their tongue doesn't move around as much, anterior open bite. Interventions we might need to augment or oral hygiene instruction, semi-reclined position. If they're having gastrointestinal problems, they might not want to be reclined all the way back. Nutritional counseling, because they're going to have difficulty with eating, perhaps eating softer foods that could be more cariogenic. Antimicrobial mouth rinses, salivary replacements if they're having xerostomia, isometric exercises to maintain mobility of muscle and face and neck to help improve opening of their mouth. And here's just a picture of some of the salivary glands, because we're going to talk about Sjogren's syndrome next, and that can affect obviously the oral cavity with saliva, but it can, any place that secretes moisturizing secretions can be affected, so eyes as well. So oral manifestations here, it's Sjogren's syndrome is a triad of keratoconjunctivitis sicca, xerostomia, and connective tissue disorders manifesting as a wide spectrum of severity. Some people have very mild, they don't really notice much. Some people it's very severe. Includes primary and secondary forms. But for us, the oral manifestations kind of center around xerostomia, erythematous oral mucosa, so a lot of redness in large salivary glands, especially the parotids, severe xerostomia, difficulty swallowing, altered taste, difficulty wearing dentures, fissured tongue, atrophy of papilla, candidiasis, caries. All of these are significant consequences of chronic reduced saliva. So all of those things on the oral manifestation. So of course, patient education is very important, nutritional counseling and artificial saliva, hydration, avoiding irritating foods, xylitol, fluorides, all of these things, and then antifungal therapy if they are having chronic problems with candidiasis or thrush. Systemic lupus erythematous, LSE, a disease in which injury is caused mainly by deposition of immune complexes and binding of antibodies to various cells and tissues, affects major organs characterized by periods of remission and exacerbation. So this kind of sounds a little bit in the same way like MS, with those periods of activity and inactivity. 5 to 25% of patients have an oral lesion associated with lupus. Location of lesions, oftentimes the palate, buccal mucosa, gingiva, may appear like a lichenoid, like a lichen planus, may look nonspecific or granulomatous, so like a granular, like or like a little like lumpiness in the cheeks, ulceration, pain, erythema, hyperkeratosis, xerostomia, taste ulceration, oral mucosa pain, candidiasis, and perio. Those all kind of go underneath the symptoms, or the symptoms that can occur because of xerostomia, like with Sjogren's. Pre-medication, possibly if they're immune compromised enough, so you have to evaluate for that. Antifungal therapy if candidiasis is a problem. Topical pain control if their oral lesions are very uncomfortable, if they have symptoms there. Monitor nutrition, caries and saliva, avoiding thoughts on saliva substitute and prevention of caries. Avoiding spicy foods. Meticulous oral hygiene, so education, so they have to know the consequences of their diet and lack of oral hygiene and of a dry mouth. Those are all very important. And then shorter appointments due to just their patient comfort level and stress. Chronic cutaneous lupus erythematous, oral manifestations, painful lesions are particularly identical to lesions of erosive lichen planus. So very kind of raw areas that kind of jump around in the mouth. Refer to a dermatologist or a physician, and then patient education on just pretty much like sort of palliative pain control and avoiding things that would be irritating, like spicy foods that would be irritating to the oral mucosa. So always thorough health, oral and pharmacological history. Priorities, we have to think about what's the priority, oral health or medical health. Possibly we may need to postpone dental hygiene care if their medical care is more pertinent. Dental hygienists may aid in diagnosis of autoimmune disorders. Depending on the characteristics that they see, we could refer to physicians. And then we just have to always consider our modifications for these various conditions. During the assessment phase, it is of the utmost importance to obtain a thorough health, oral, and pharmacological history from the patient to identify conditions that warrant referral for medical evaluation. The clinician must be able to determine if the need for medical care supersedes the need for oral care, whether it is safe to provide treatment, and what the patient will be able to tolerate in terms of appointment scheduling and procedures. And oral care may have to be deferred until additional medical evaluation and or treatment is provided. Dental hygiene practitioners can measure the oral health related quality of life through two different scales, the Modified Oral Health Impact Profile, or the OHIP, and the Mouth Handicap in Systemic Sclerosis Scale, MHISS, which is what this scale is. So this is for patients with systemic sclerosis. Comparisons can be made in a patient's quality of life using these assessments at different appointments and as their autoimmune disease progresses or treatment regimen changes. The dental hygiene student should determine those needs that can be improved through the delivery of dental hygiene interventions and identify referrals needed for further dental hygiene and those with other healthcare disciplines based on those dental hygiene diagnoses. So we have to assess what's going on with our patient and then think about who we might collaborate with or share that information with based on the patient's other conditions, what other kind of systemic diseases or conditions they have. So for final thoughts, autoimmune diseases are multifaceted and present challenges to general and oral healthcare professionals. Given the nature of these diseases, patients may present with multiple needs that affect dental hygiene care. Using the dental hygiene process of care ensures adequate planning for the delivery of safe and comprehensive oral care. Consultation with the patient's physician may be necessary to complete the planning process to ensure patient safety. For example, a patient who presents with multiple sclerosis should be scheduled for treatments during periods of remission and may need steroid supplementation during their appointments. Implementation includes the administration of dental hygiene interventions to minimize oral infection and restore oral health, prevent future disease, and includes patient education. Patients must understand the relationship between their autoimmune condition, medical management, and oral care. So it's our job to kind of talk about all those different things and how they relate to each other. Patients don't always know how their systemic disease relates to their oral health. Some patients may require further care with an oral specialist if mucosal lesions are not responding to initial treatment protocols, and others may need more definitive periodontal treatment. In these instances, referrals to an oral pathologist, oral surgeon, or a periodontist may be warranted. So we always want to document how the patient is doing and if anything is changing, so we can kind of monitor our process and the outcomes and see that we're getting the outcomes that we want. And that, oops. And like I said in class, this is just an overview. What do we use fluoride for? Caries risk reduction and hypersensitivity. What do we use non-fluoride remineralization therapies for? Caries risk reduction and hypersensitivity. What do we use xylitol for? Caries risk reduction. So you can just kind of go through this. Saliva stimulants like pilocarpine and cevimeline, I think I'm saying that right. These boost saliva production. And then we have saliva substitute, which is just over-the-counter, rinses and gels and whatnot. Antimicrobial agents for oral disease risk reduction, halitosis, medical mechanical devices, all of our plaque removal for biofilm removal and oral cleansing. So just kind of a little overview product consideration. All right, thank you guys. Have a great afternoon.